Hello everyone, my name is Dr. Parissis and welcome to another video. I recently made a video where I talked about how the average patient who wants full hair restoration should likely do FUT or strip surgery before doing FUE, follicular unit extraction. Now, I've had quite a few responses to this video, and one very valid question that I've been getting is, why do we have to do FUT first? Why can't we do FUE, test the waters, and then, do FUT at a later date? And that way you'd be avoiding a scar, at least at the start of your hair restoration journey. Now, I've got a case study that I want to go through, and I've got Dr. Bloxham here. Thanks for joining me today.
Absolutely.
Who I thought I'd ask a few questions to about this particular patient's case. Here we've got a 33-year-old gentleman who, he'd lost a good amount of hair, and he went to Turkey very recently, actually, and had a very large FUE procedure. So specifically, he had 4,150 grafts via FUE, meaning that the surgeons in Turkey individually extracted 4,150 grafts from the sides and back of the head, from the safe donor area, in other words. So they did this, and I really wanted to show you, Dr. Bloxham, the safe donor area to begin with. This is after the procedure, specifically 10 days after the FUE procedure. And this is a side shot, okay? So I'm going to ask you a few questions about this, but I'll show you it first. So you can see this is a side shot on the right-hand side. This is the, obviously, a rear shot. If you want to take a good look at that, just see where the punches are. You can see quite a few at the, near the neck area, dotted all around, really. This is the left side. We can see very similar to the right.
Yeah.
Now, if I continue, we can see where they put the grafts into. So first of all, they actually peppered some grafts into the crown area. This patient had quite significant loss, and he wanted to really knock out both the crown and the frontal third of the scalp as well. So you can see this is the crown, and I'll show you, that's another shot of the crown. And this is the kind of the frontal third and part of the mid scalp as well, that was really knocked out.
How many days post-op is he now?
So he's 10 days. 10 days. This is 10 days.
First things first, tell him to wash his transplant.
Yeah, you're right. Yeah, there's a lot of crusting there.
Yeah, that's not good. If you're watching this video and you just had a transplant, you don't want your transplant to look like that. Buzz cut.
Yeah.
Think buzz cut.
Yeah, you've got a lot of videos on that, Dr. Bloxham, don't you, about how to wash properly?
I have a lot of patients that are afraid to wash, and I understand it, but I tell them that I would never say to do anything that would hurt that hair. I'm the only person on the planet Earth that wants it to grow better than they do, so wash your transplant, guys.
Okay. Here's another great shot from the top. You can kind of get an idea of where they put the hairline as well. And that's another shot from the right.
Are those scabs in the very front of the hairline, or did they put are those grafts?
That's a great question. I mean,
kind of interesting.
Just zoom in here. Can you see the zoomed in version here?
Yeah. No, they look like they're it's hard to tell. I bet you they did some kind of standalone singles there, some of those sentinel singles in the hairline there. Yeah.
Okay, so right off the bat, as I said, this guy, he's 33 years old. He had a significant loss. He went to Turkey seeking full hair restoration. He didn't want to get the linear scar with strip surgery, opted for FUE, really wanted the best result possible in a single procedure, and really just wanted to forget about hair loss. He wanted this procedure, and then he just wanted to forget about hair loss. Okay.
Yeah.
So my first question for you, Dr. Bloxham, is, what's the main problem that you see with what this patient has had done?
So, first of all, the setup that you presented there is to what this patient, wanted, why he was seeking hair restoration, wanting to just knock it out of the ballpark and never think about it again. I understand that. Who doesn't want that? I get that. I'm empathetic to any person who says, I just want to do as much as I can and let's get this done. Who wants to hear you need to come back from multiple surgeries, it's going to progress, etc. However, that's the first problem that I see, is that this patient had expectations that in my opinion were not reasonable, or not, I shouldn't say reasonable. Of course it's reasonable, not realistic is a better way to put it. And the first problem that I see with this case is that he probably never consulted with a physician who said, look, I get it, who wouldn't want that, but here's the reality of it. He probably consulted with, a salesperson who's compensated based upon how many, people they're able to get through those doors in Turkey. And that salesperson probably told him, of course we can deliver this to you. Of course we can give you a full head of hair. Of course we can do it all at once. Of course you will have, no scars. That's just kind of the way the model is over there. There's a lot of clinics. The competition amongst the clinics is intense, and they're undercutting with prices and packages and things like that all the time. So, this is what we're seeing. However, the second problem after that is, if you look at this patient's, supply versus demand. He had a lot of demand on top, a lot of what appeared to be bald hair, bald scalp on the top. This guy looked like he's probably in Norwood 5 currently and progressing. And his, supply in the back, as it always is with all patients, but particularly with high Norwood patients, was limited. And so the issue is, if you want to get out these high graft numbers on a guy like that, and you want to not put him in a bad situation on the road, you have to use that donor very efficiently. And what they did is they did not use the donor efficiently. By definition, FUE is always going to be a less efficient way to utilize the donor. And I won't get into too much of that because that's a whole 20-minute video there. But the second problem is that they didn't use that donor, too efficiently. And then in order to get those high graft numbers that he needed, they had to do something that almost all clinics offering large FUE sessions do, which is they went outside of the safe zone. Initially you kind of started this video talking about the safe zone. And for any patient watching this, I would encourage you just to Google a doctor named Dr. Unger, a guy named Dr. Unger, doctor here in New York, sort of one of the pioneers in this field. But he was one of the ones who originally mapped out, just through his experience and very careful, considered research, he mapped out, hey, what's really safe, what's really not safe. And if you have a patient that's going to progress to that level, anyone's going to progress that level, you really only have, that kind of what I would consider like that horseshoe, that very kind of contracted donor area that is safe. But that donor area can only be accessed and give you high graft numbers if you're taking a strip, closing it up, taking another strip, closing it up. If you're going to try to do FUE in a patient like that, you're going to have to do one of two things. One, you're either going to have to just stay in the safe donor and just destroy it, turn it into a desolate wasteland where literally it'll be like one of those patients we see from Turkey that just has these patches, these slick bald patches in the back. Or number two, you're going to use what some doctors and clinics like to call the expanded donor area or the safer donor area. And what that means is you have to push and extract from places that might not be safe in the future. And that's exactly what they did here. And that's the problem number two, is that just in that picture you're showing right there, Dr. Parissis is a perfect example. They harvested up so high on this parietal region, the side region here on this gentleman, that we have no idea, if those hairs are remotely resistant to DHT. Just because there's hairs in that area now doesn't mean there's going to be hairs in that area in a couple of years. This is not by definition safe donor area. So in order to get those high graft numbers out, and in order to give this patient what he quote unquote asked for and wanted, they had to harvest from all over the place. And we see this all the time. They had to go way up too high on the sides where you're almost in like the recipient area. And it looks like they did that on him. You can see that kind of reddish coloration to the skin there. That's where they took the grafts from. And you can see it's right next to where they put grafts in, too high up there. They also, in some of those pictures, you can see they went way too far down into the nape of the neck. Perfect example there. On a guy like that, a young guy like that, we just have no idea if that area is safe. And if I had to bet, if that was my brother or my cousin or something like that, and he asked me, should I take grafts from here? I would say not in a million years. Because what's likely to happen is he's going to continue to progress. And he's going to see not only more loss on the top, but he's going to see changes around the periphery of what, is generally considered the donor area. He's going to see these parietal humps dropping. He's going to see a little bit of retrograde alopecia where that nape comes up this way. And then what he's going to find is his transplants are going to start looking worse on the top, and he's going to start developing just bald, skin without hair that's peppered with these little FUE scars, meaning that literally all that hair fell out. So now he has a bald skin here with FUE dots in it. And not only does he not have the hair there and he has the scars there, he doesn't have the hair there anymore. So that was the biggest problem they did. And now that patient is in a situation where, he's kind of stuck here, where he did a lot of FUE and now we're in sort of a tricky situation. And then the last problem that they did with this guy is, I think they tried to sort of do too much of everything. The frontal third looks pretty good as far as density goes. It's hard to tell with that scabbing, but it looks pretty good. But what they did in the crown, I don't think that's going to give him a cosmetically significant benefit. Maybe he didn't care. Maybe he's just looking for a little bit of kind of like a haze back there. But that does become a problem with skipping around and working in different areas, or telling a patient, I'll do everything at once. The reality is, and you've seen this many more times, look, even in there, sorry to interrupt myself, but you can see, look at how that crown is expanding. And look at how close that is to where they harvested. He's going to likely be in that scenario that I described before. I hope I'm wrong, but I'd say there's a high likelihood of that. But as you've seen many times before, Dr. Parissis, in consultations and stuff with me, is I always tell patients, you need to look at the scalp front to back as more like two discrete procedures, frontal half and back half. It usually takes about 5,000 to 7,000 grafts to do everything from front to back. The vast majority of patients, regardless of the way you're harvesting it, really think more like 2,500 to 3,500 is sitting. That's what's more realistic for the average patient. Sometimes you can do more, that's great. But 2,500 to 3,500 is going to allow you to do one half of it. So kind of look at this as two halves. Knock out the front half first, then worry about the back half in the future, especially in a young guy where that back half is still evolving and changing. So that's what I think problem number 3, kind of final problem here is that that wasn't properly explained to him. And I don't think he's going to be as satisfied with that crown. And for all I know, those crown grafts may have come from those unsafe areas. So it would have been better to just leave it and take out less grafts and focus more on that frontal area, or take some of those grafts and put them in the frontal area.
Yeah, I 100% agree with, absolutely everything you said there, Dr. Bloxham. One thing I wanted to highlight is I've seen quite a lot of you guys actually commenting that, because of my affiliation with Dr. Bloxham and Dr. Feller, and because of Dr. Bloxham's experience with FUT or strip surgery, that, there's a bias there, that there's a bit of a, we dislike FUE, and that's really not the case here. And I want to just stress, this in this video. We're not here to bash FUE. We're just trying to highlight the correct situation where FUE is appropriate for the patient. And would you agree, Dr. Bloxham, that in this case, this patient, FUE perhaps wasn't appropriate, or wasn't the best approach for this patient?
Completely. Yeah, I agree with what you said. It's funny. I get accused of a lot of the same things online. And I don't look at it as a bias. I look at it as, I'm very proud of the fact that our clinic is what I consider a hair transplant institute clinic, where we can, not only are we a standalone clinic, big setup where we can do just about anything, and that's all our focus is hair. But we can perform both FUT and FUE. And I think sometimes people look at it as, the fact that you could do FUT or that you like FUT means you're biased one way versus the other. I don't see it that way. I typically can come up with a plan, an FUE plan for just about any patient, but it wouldn't be a plan like that. I wouldn't say let's blast out the donor with 4,000, 5,000 FUEs and sort of, do whatever we want on top or whatever we can on top. And I think you're going to touch on that, so I won't go too far down that alleyway there, but I don't think it's a bias by any means. I think that, like you mentioned, there are patients that are better suited for one versus the other. And if you're able to only offer one surgery, of course, you're going to be biased towards it. And that's why a lot of these places will say, no, you should just do FUE. FUT's outdated. You're going to have X, Y, and Z problem. But if you're able to do both and do both well, and I think we're very good at FUE here. I would sit down next to any FUE guy in the world and show them what I do and have them show me what they do. And I think, it would be very, very much on par. I'm very, very proud, very comfortable with the way we do FUE here. And we do a lot of it. It's not like I do one FUE case a year or whatever. We do a lot of FUE here as well when it's appropriate. But the situation isn't a bias. It's just that there are patients that are better suited, just objectively better suited for one harvesting method versus the other. And if you're able to offer both procedures, you can recommend the right one to the patient. And like you said, this guy, in my experienced opinion, is much better suited for FUT. I think the only way to really get what he needs on the top, if he's looking for, that really full coverage to be able to grow his hair out, I think the only way to get that is to start with FUT. He really probably should have considered, a larger FUT surgery to start with here.
Yeah, no, 100% agree. And it's quite simple. I do want to stress this one more time. It's not FUT only. That's not what we're saying. It's not FUE only. It's both. And that's
Absolutely.
the key word.
Absolutely.
It's just that is the buzzword that we really want. If you take one thing away from this video, it's go to a clinic that does both. Simple as that.
Even if you're convinced that you want to do FUE, even if you're convinced that that the clinics over in Turkey or Spain or India or one of these other places, that they're doing something with FUE that other people aren't, be evaluated by a clinic that can offer both and get their objective opinion on which would be better suited for your case. And I agree with you that I think patients should seek care regardless of the surgical method they're going to go at a clinic that can do both, because I think that there are quality standards that are met at a clinic that can do both that aren't necessarily met at a clinic that can only do one. There are things you have to have and be able to do in order to offer both surgeries. And I think that's what you want as a patient. You want to be able to go to these clinics that have met these metrics, because you have to meet these metrics to offer both.
Yeah. And just to return to this specific patient's case. So as I said before, he's had 4,150 grafts. Now, Dr. Bloxham, would you say that that is a lot of grafts? Would you say that this patient has more in the tank, and if he does lose any more, he can do more FUE? Surely he can just do more FUE.
It's a lot of grafts, no question. It's a lot of grafts via either method. I do 4,000 graft FUTs, pretty frequently. Most patients, as I sort of mentioned before, we see a lot of these huge numbers online. Most people, when you really push to get as much as you can, it's closer to that 2,500 to 3,500 range. But I'd feel much better about his situation if he had done 4,000 FUT versus FUE. Having said that, yes, 4,000 grafts, that's a big number, kind of no matter how you slice it. Now, can this patient get out more grafts? My answer is most likely yes. Thankfully, most likely yes. As to how he can get them out, I think that's going to be a more complicated sort of nuanced discussion. He's probably going to need to really be evaluated by somebody who's very, very good, particularly very good at FUE. I think that's probably what he's going to need at this point, is to do more FUE, and we'll sort of touch on that, I assume, in a minute. But one thing I would add here, another problem with FUE only approaches to surgery is oftentimes patients find themselves in this scenario. They were convinced that this big massive FUE was the way to do it. They did it. The donors kind of tapped out. And when they go seeking more, that's when people start recommending things like, let's rip them out of your beard. Let's take them out of your chest, your legs, arms. I've seen it all. And that's not ideal practice, in my opinion. And I know it sounds good on paper. There are a lot of things in this field that sound just fantastic, so awesome on paper, that just don't pan out in reality. And I think body hair grafting in particular is one of them. So what I always tell patients is, if you have scalp hair left, do scalp hair. That's the best way to do it, is scalp hair. If you have absolutely no other options, then okay, there's a conversation to be had there. But if you have scalp hair left, do scalp hair. If you're considering a body hair, putting body hair on the scalp, and I won't get too much into the details here, but find someone through the internet that has had it done, and see them in person, and see what you think about how that body hair looks on the scalp in person, before you let another salesperson convince you that don't worry about the fact that you're out of donor grafts, take them out of the beard. You can take 2,000 grafts out of the beard, and then when that's done, we'll take 1,000 grafts out of the chest. And then when that's done, be very cautious about that.
Yeah. Before I continue with this patient's case, I did want to say that just on that topic, it's very easy to be fooled into thinking that beard grafts, chest hair grafts look just as good as scalp hair grafts, as you said, and that's because, as you said, most of the time it's very rare that the surgeon will take only beard or chest hair grafts and kind of give a final result. They'll mix the two. They'll mix the scalp grafts and they'll mix the chest and hair and beard grafts, and that can give a false impression. Those scalp hair grafts can really support those beard and chest grafts and make it seem like there's that those grafts are
like the beard grafts or what
exactly
led to that result. Not the case.
And it's not necessarily the case. When you really pick through, when you put water on that hair, you're going to see a difference between those body hair grafts.
Or look, just try to grow it long. Try to grow it long. Again, I won't. I know I have a tendency to talk too much and to to just go into too much detail. But there are do a little bit of online of research. Do a quick Google search and just search for the anagen, the growth cycles of different types of hair follicles. What you're going to find is that the reason why you can grow your scalp hair, down to your ankles if you want, is because scalp follicles have a growth anagen cycle that's anywhere between like 2 to 7 years, with about 3 to 4 years being the average. So on average, a healthy scalp follicle is going to grow hair for 3 to 4 years, maybe 7 years. You can grow that pretty long. Beard hair is a couple months, if even. And what that means is that it's only going to grow, hair for a couple months, and then that follicle is going to slow down and stop and go into a resting phase, and that hair is going to shed. And that can be very frustrating for patients because they've got these scalp hair grafts that are growing normally, and they have these beard hair grafts that are just growing, a few centimeters, shedding, a few centimeters, shedding. And so it's just not giving them that density because half the time it's not there, So that's another thing to consider with these body hair grafts.
Yeah. Obviously, we have so much to say about hair restoration surgery, Dr. Bloxham,
Too much.
As I said, I want to remind you guys the title of this video, and the main question is, can we do FUE and then strip surgery? And to tie back to this patient here, I want to ask you, Dr. Bloxham, this patient's had a big FUE. Can he have an FUT? Can he have a strip surgery in, say, a year or two if he loses more hair?
Mm-hmm. So, the simple answer to that is yes, of course he can, presuming he has normal laxity and all that good stuff. Yes, he can. The real answer to it is far more complicated. The scenario of going from FUE to FUT is not the same as going from FUT to FUE. Like you said in the comments in the past videos, I'm sure everyone says, well, just do a little FUE first, do FUE first, then if you need to switch to the strip, that way you're avoiding some of the problems. There were even clinics back in the day that used to literally leave like the actual good part of the donor unharvested, and they would FUE all around it and leave that area for a strip. Problems with that as well. But the long story short is that if you do strip first, what's nice about doing strip and then doing FUE, as you had mentioned, that's really what this is about, is being able to combine both methods to really get out everything that you can in a patient that needs everything like that. The reason why doing strip then FUE works is because with strip surgery, you're not doing something that is the crux of this entire argument. You're not decreasing the global donor density. You're not decreasing the number of grafts back here per square centimeter, because you take a big strip and obviously you're taking out hair with that strip, so that hair is going somewhere, but then you're taking that defect, that area that was left behind once you remove the strip, and you're reducing it, and you're closing it up with stitches or staples, and it's healing into a little scar that's much smaller than the strip that you took. So in doing so, you're reducing the numbers of hair, but you're also reducing the surface area, and reducing both the, that's all density is, the measurement of grafts per square centimeter. So if you're removing grafts and you're removing square centimeters, your density, your global density, the equation in the end is going to be roughly the same. So with strip, you can go in and hit that multiple times. And aside from that little scar, that's obviously void of hair, the density everywhere else is unchanged. You haven't touched that. So if your density back here was, 80 follicular units per square centimeter before, 2 strip surgeries, it's still 80 follicular units per square centimeter after 2 strip surgeries. So now we've done a couple strips, maybe the laxity is a little bit less back there. Maybe the scar is in very good shape and the patient wants to do more. Great. You've got now 5, 6, 7,000 grafts to strip. Now we can go in and carefully do FUE because the density is unchanged. So now you've got this perfect virgin density in a sense to do FUE. So you can FUE all around it. You can be a little cautious around the scar, but you can access all these areas that you couldn't access as a strip. And you can take a good amount because you have not thinned out the density. When you do FUE first and then try to switch to FUT, the problem becomes FUE always decreases the donor density, the global density, because you're taking hair out and you're just leaving an empty hole. So you're creating these little areas that are void of hair. Now they can be very small and the scars can be very good, but you're still creating these areas that are void of hair. And by reducing the density, reducing the number of hairs without reducing the surface area, you're creating a problem. You're creating a scenario where there's the same amount of surface area, but there's less hair, and now you have a decrease in global density. The problem there is that you can only decrease that global density to a certain amount before it's tapped. And it looks thin, it looks patchy, and you simply just can't take out any more. So let's say this patient in that scenario, this gentleman that you're using as the case example here, let's say he's done that. Let's say he's really hit that. They took, maybe 50% of the density he had back there. Okay, now that density is low. Do we want to take more FUE? It's kind of hard to do because you've already dropped that density a lot. So, okay, fine, let's switch to strip at this point. Well, here's the problem. Theoretically, can you take a strip? Like I said, sure, there's nothing prohibiting him physiologically from taking a strip. But let's think about what's going to happen with that strip now. We're going to go in and take out a 30 centimeter strip from ear to ear, a scenario that normally in a patient with that 80 follicular units per square centimeter density is going to yield 3,500 grafts, something great. Now, because half of those grafts are missing, because remember, we picked through and we left open holes, we're going to take a big strip on that patient and we're going to get out 1,200, 1,500 grafts. And that's upsetting. That's disheartening for patients when we're swinging for the fences and going for those big numbers, and we're taking a big piece of tissue from back there, and you get those small graft numbers. So that's a problem number one, is if this guy needed 3,035, something like that, we're only getting out 15. That's a problem. Second problem with going from FUE to FUT is now you have a linear scar, and kind of regardless of how the linear scar heals up, you're always going to want to have some hair there to cover it. If this patient had, virgin density all around there, if he had 80 follicular units per square centimeter and he had a good, nice little normal linear scar, he may be able to go down to like a number 2 or 3, probably number 3 on the buzzer before you saw it. If he has half the density he has back there, he's going to have to wear his hair long to cover up that strip scar. So now he's in a scenario where he didn't get out as many grafts as he wanted to. He has to wear his hair longer in the back, and he's kind of stuck. So that's a tough scenario to go from FUE to FUT. Just mathematically, the approach doesn't work out as well. FUE, in my opinion, was really, or should have really been designed as like an adjunct to strip surgery. You do as much strip surgery as you can. You hit the best part of that safe donor area. You get out those highest quality grafts. You do the least amount of damage back there. And then, bonus round, we can take FUE from here, and we can take it in decent amounts because we have not reduced that density. When you try to flip the script, the pieces just don't fit together. And I get a lot of patients that do come to me in that scenario because they're like, all right, you're the FUT guy. I saw you on YouTube. Fix it. And I have to tell them, I'm sorry. It's not that I can't do a strip. It's that you're going to run into these problems that I just described, and it may not be worth it for you in the end. It may be better to just send you to a really high quality SMP clinic and have them kind of, even things out there and call it a day. Maybe worth it to see, is another question you're asking here, if we can do a little bit more FUE, even though it's probably going to leave the donor in bad shape. And remember, it's always harder to do subsequent FUE because the tissue back there is scarred up all over the place. So it's harder to get those grafts out. A lot of times they don't come out well. A lot of times they grow worse on the second round with FUE because there's just more trauma inflicted upon them. You may have to take that route. And that's probably what this guy's going to have to do. My guess is that when that's all totally healed, I'm hoping I'm wrong. I'm really hoping I'm wrong. But my guess is that it's probably going to be thinner back there than he wants it to be. And switching to strip surgery, it might not be advisable at that point. Especially if he really wants to get a lot of grafts with the strip. If he's generally happy with the FUE and he's like, look, the front grew in well, happy with that. Coverage in the crown is adequate, but I've lost the bridge, the sides have dropped. he wants to do, a small strip, maybe just take it from one side, maybe do like what I call like the modified approach where you break the strip up into little pieces. Okay, that might be doable. But if he says let's do one of your big strips to get out 3,500, sorry, you just can't do it because it's been depleted back there, and you're gonna have a hard time hiding an incision line like that.
Yeah, so there you have it, guys. This video emphasizes really that FUT and then FUE is really the best way to get the most number of grafts over your lifetime and this is especially important for those with advanced hair loss. We're talking about patients who are at least a Norwood 5 on the Norwood scale, patients that are very young and they've experienced significant loss. These are the two groups of patients really need to consider FUT first. All right, so unfortunately that's all we have time for today. Dr. Bloxham, thank you so much for joining me.
Absolutely.
I hope you guys learned a good bit about FUT, FUE, and the order of which to do them, which one might apply to you more. Thanks very much for watching, and see you in the next one.